I hope I'm audible. So, good morning to all. I have great pleasure in introducing Dr. Gopikrishnan, who was an alumnus of Sri Chitra, and thereafter he did his fellowship in neuromuscular disorders in NIMHANS at Bangalore. And as you can see, his publications are over 30, and although he has not put up much about him, there's more versatility into his day-to-day clinical practice, as we all know. So he's today going to enlighten us on the various kind of neuropathies which are associated with hematological disorders, which is an important topic. And as a neurologist, we should all be aware of these kind of presentations. So let us hear from Gopi, and after the end of the session, if the time permits, we can have a few queries from the audience as well. So over to Gopi.
Thank you, madam, for the kind words. So, one minute. Are my slides visible?
Yeah.
I hope it's visible, right, ma'am?
Yeah, it's visible.
Okay, thank you. So I'll be speaking about the spectrum of neuropathies in hematological diseases. So hematological diseases, they offer a very unique spectrum of neurological disorders and neurological complications. So it's important because many a time it may be the neurology problems or the neuropathy which brings the patients into the hospital, and we may be the first doctors attending to these patients. So it's important to be aware of these situations. So hence this topic. So before I begin, there's a few caveats about this talk. This is in no way going to be a very extensive elaboration of each of these topics. It's just a basic overview of various types of neuropathies that we do see in hematological disorders. So I will be speaking about paraproteinemic neuropathies, hyper-eosinophilic syndromes, neurolymphomatosis, and briefly, if time permits, about chemotherapy-induced neuropathies as well. So we'll begin with paraproteinemic neuropathies. So when we talk about paraproteinemia basically happens in the context of a clonal proliferation of plasma cells or B cells. Clonal proliferation means that, sorry, just 1 minute. Yeah. So clonal proliferation means that there is a neoplastic process usually which is affecting one of these plasma cells or lymphocytes occasionally, which leads on to proliferation of these plasma cells. And all the clones from the same plasma cell will finally produce the same sort of protein, the same sort of immunoglobulin. So that is what appears as these monoclonal M bands, and they are the paraproteins which are responsible for these neuropathies. So now there are various mechanisms by which these paraproteins can lead on to a neuropathy. Important ones being a protein deposition related. The important ones in this would be amyloid and IgM deposition disease, which is a very rare entity. We won't be talking much about this. So then these antibodies, they can cause a direct injury to the nerve, either directly by the antibodies or by complement fixation. So that leads to some neuropathies like CANOMAD or CANDA, anti-MAG associated neuropathies and cryoglobulinemia. And sometimes you can have a very pro-inflammatory state in association with this paraproteinemias, and then you get neuropathies like the POEM syndrome. So we'll begin with a case. So this is a 54-year-old gentleman. He had presented to us with 2 episodes of syncope, both of which were orthostatic episodes. He was recently under evaluation for weight loss, loss of appetite for the past 6 months. He also reports recent onset paresthesias in the feet, occasionally painful, and examination showed significant orthostatic BP fall, falling to 70 systolic and standing. And he had some neuropathic symptoms, especially in the lower limbs. The ankle jerks were absent, vibration was impaired in the toes. And this is the patient's conduction. So just to go take you through it, it's basically an axonal polyneuropathy. There are no demyelinating changes. The CMABs are reduced in the lower limbs. The SNAPs are absent in the lower limbs with no demyelinating features. So overall looks like a length-dependent axonal polyneuropathy. And again, the investigations, I'm not going into all the investigations done for this. So the relevant investigations, the complete blood counts were normal, ESR and CRP were normal. The electrophoresis, serum protein electrophoresis did not show an M-band, but the immunotyping, that is the immunofixation electrophoresis, showed a lambda monoclonal band. And the kappa and lambda free light chain show a disproportionate increase of the lambda free light chain, with the ratio being 0.25, the normal ratio being 0.26 to 1.6. And the IgG, IgA, IgM levels were normal, basically implying that there's an isolated lambda increase everywhere. And because of the prominent GI symptoms, the patient had undergone a biopsy from the GIT. This was from the gastric canton, which showed extracellular eosinophilic material, which was congruent positive, suggestive of amyloid. He also underwent a bone marrow study to make sure that he didn't have an myeloma, and that showed just 5% plasma cells, and he didn't have any CRAP criteria to call it myeloma. So, which brings us to the first paraproteinemic neuropathy, that is amyloid polyneuropathy. So there are many types of amyloid polyneuropathies. So in the context of hematological disorders, we are more interested in the AL type of amyloid polyneuropathy. Of the various types, it's the AL and ATTR which presents with neuropathic symptoms. The rest of them, the neuropathy is not quite prominent. So ATTR, again, I'm not speaking much about ATTR. It can be a variant ATTR or a wild type ATTR, genetic or acquired variants. But we are more interested in the AL amyloid causing neuropathy. So what is AL amyloidosis? So AL amyloidosis happens again when you have a monoclonal plasma cell proliferation and you have excess of light chains which sort of get modified and get deposited, forming a beta pleated structures, and this gets deposited in all sort of tissues. And when they get deposited in the nerves, you get polyneuropathy. This is called the amyloidotic polyneuropathy. So when do you suspect somebody to have an amyloid-related polyneuropathy? So usually they present with sensory neuropathy with lung-dependent sensory symptoms with prominent autonomic symptoms. So what really flags you towards an autonomic neuropathy is the prominence of the autonomic symptoms. This may be orthostatic intolerance, this may be GI symptoms, episodes of diarrhea, constipation, gustatory sweating, genitourinary symptoms, all sort of autonomic complications. In advanced stages, they can have motor involvement as well. Entrapment neuropathies, especially carpal tunnel syndrome, is quite common. Rarely you can have weakness because of amyloid deposition in the muscles as well, but this is quite rare. And usually the patient have associated constitutional features with weight loss, loss of appetite, fatigue. And when you are evaluating for an amyloid polyneuropathy, the important investigations would be to do an immunofixation electrophoresis. The serum protein electrophoresis quite often may not pick up the M-band. Immunofixation also may be negative in 20% of the cases. The kappa and lambda free light chains are very useful in the setting of amyloid because usually the monoclonal protein is a lambda light chain in the case of amyloid. So you're not just interested to know if how much the kappa and lambda are elevated. You need to have a disproportionate increase in the lambda light chain as compared to kappa with a skewed kappa lambda ratio to really say it's a clonality is there. So urine protein electrophoresis and immunofixation electrophoresis are other options which can be done. And finally, nerve conduction studies, usually it shows a lung-dependent axonal sensory motor polyneuropathy. Sometimes it may be normal also because of the prominent small fiber symptoms. Rarely you can have demyelinating features. Now, it's important to demonstrate the deposition of amyloid in tissues to really say that this is an amyloid-related pathology. So nerve biopsy can be used when the patient presents with neuropathy, but your yield is not very great. Even when you have neuropathy in amyloid, it may be as low as 30% when you're sampling the sural nerve. This is because amyloid deposit is often very patchy, and unless you sample an area of the nerve which has an amyloid deposit, you may miss out on the pathology. Other areas we usually biopsy, one is the minor salivary gland, abdominal fat pad biopsies, rectal and bone marrow are the other sites we look for to see if there is amyloid. And based on any specific other organ system involvement. For example, if you have prominent macroglossia, then minor salivary gland biopsy is a good option. If you have proteinuria, renal biopsy would be a good option. And then there is a amyloid neuropathy with a family history. Obviously, we think of familial amyloid polyneuropathy, go for genetic evaluation in this context. Few other clues maybe you can do an echo to look for cardiomyopathy. NT-proBNP tends to be elevated, especially when there's cardiac involvement. And if you have a renal involvement, there may be signs of proteinuria and renal dysfunction as well. Treatment is for AL amyloid, it's treated quite similar to myeloma because it's essentially a plasma cell problem with daratumumab, cyclophosphamide, bortezomib, and dexamethasone being the usual regime followed. And variant amyloid polyneuropathy, that is the genetic variant. Tafamidis is the option which is available in India, but patisiran and inotersen are two treatments which are FDA approved but not yet available. So moving on to our second case. So this is a 54-year-old male. He is diabetic for 4 years but well controlled. He came with 4 months history of paresthesias, cotton wool sensation in the feet, losing footwear, orthostatic intolerance, constipation, excessive sweating. Basically, some length-dependent neuropathic symptoms with some autonomic symptoms to start with, developing over a 4-month period. Now, examination, he had lymphadenopathy in the cervical regions. He had thickened and hyperpigmented skin, hypertrichosis, and you can see all these in the images, the hyperpigmentation, the hypertrichosis. And the cranial nerve examination, including the fundus, was normal. He had a weak toe grip, absent deep tendon reflexes, and impaired vibration. All sensations were impaired in the field. Very symmetric symptoms. So again, this conduction was showing a significantly demyelinating picture with prolonged distal latencies. All the velocities are quite reduced. Amplitudes are fairly preserved. There's a bit of conduction blocks as well. All the FWaves are prolonged. The snaps are all absent. So basically, with in the setting of a demyelinating polyneuropathy. So somebody presenting with a demyelinating polyneuropathy developing over 4 months with skin changes, lymphadenopathy. So the investigations, he had a bit of polycythemia. HB was 17.7. The rest of the blood counts were normal. His HbA1c was 8. His serum kappa lambda ratio was slightly skewed. There was a predominance of lambda, but it was still within normal limits. The electrophoresis showed an M-band, and serum immunotyping was confirmed that the M-band was in the IgG lambda region. And he underwent a MRI brain also as well as a PET-CT. So both of it showed this osteosclerotic lesion with FDG uptake in the right mastoid region. So he was diagnosed with POEM syndrome. So basically what is POEM syndrome is, it's a paraneoplastic condition which is driven by an underlying low-grade plasma cell neoplasm. But all the pathologies, all the manifestations of POEM syndrome that we see are mostly dependent on, are caused by a cytokine overproduction, most important of them being a VEGF. So usually happens in people 40s, 50s, that is the usual age group, slightly older. And it generally does, it's a subacute course. The neuropathy patients usually present with neuropathy in these, and they develop over a period of weeks to months. So as the acronym suggests, POEM stands for polyneuropathy, which is usually demyelinating. Organomegaly, usually hepatosplenomegaly or lymphadenopathy are seen. There is evidence of endocrinopathy. Hypogonadism is the most common pathology seen, but you can have other sorts of endocrinopathies as well. Skin hyperpigmentation. So among skin hyperpigmentation, among skin changes, hyperpigmentation is a common manifestation, but another quite classical manifestations are these things called hemangiomas. So you can see in the image these small lesions that you see on the chest. This is another of our patients with POEM syndrome. These are the classical hemangiomas that you see in POEM syndrome. So unless you really examine the patient for these signs, especially in patients who have demyelinating neuropathies, you tend to miss them. So it's very important to look for these hemangiomas and skin changes in patients who come with these demyelinating neuropathies. And there is a criteria for POEM syndrome. There is a mandatory criteria. So the mandatory criteria requires that there should be a polyneuropathy, which is usually demyelinating, and there should be evidence of some clonality. So there should be a monoclonal plasma cell proliferation somewhere. This can be demonstrated either by an electrophoresis or immunofixation showing an M-band, or if you have a biopsy from the lymph node or some organ or a plasmacytoma, which is showing a clonal proliferation of plasma cell in the biopsy. So you need one more major criteria among either Castleman's disease, sclerotic bone lesions, or elevated VEGF levels. So usually to screen for the sclerotic bone lesions, we do a PET scan, but you can also do a whole body stir sequence to look for these sclerotic lesions or a bone scan. And minor criteria are usually one of the following. There is organomegaly, evidence of extracellular volume overload, usually in the form of pedal edema or refractory ascites. Endocrinopathy, like we previously mentioned, skin changes. Papilledema is something which we always clinically look for in these patients. And in the peripheral blood, you look for evidence of thrombocytosis or polycythemia, again, because of the high VEGF levels. Now, treatment treatment basically depends upon whether it is a very limited lesions which are detected on the PET scan. If it's very limited, you can go for radiation, but otherwise, it's chemotherapy with or without hematopoietic stem cell transplantation, which is the treatment of choice. Now, moving on to a third entity, this is the IgM gammopathy with anti-MAG antibodies. I don't have a case for this. So this usually presents in the sixth or seventh decade of life, and usually affects men more than women. Most of these anti-MAG neuropathies will be associated with IgM paraproteins, and most of these anti-MAG antibodies, they present with a DADS phenotype. DADS, as you all know, is the distal acquired demyelinating sensory neuropathy phenotype. But few of them, they can have a typical CIDP picture also, or an asymmetric neuropathy sort of picture. But usually the conductions are demyelinating. The DADS phenotype clinically will look like they'll have distal sensory motor predominant symptoms, predominantly sensory symptoms with ataxic neuropathy. And they're very indolent disorders. They develop over the course of years, minimal weakness with reduced deep tendon reflexes. Now, this is the nerve conduction study of somebody with a DATS phenotype of MAG antibody. So, what you look for is quite characteristic prolongation of the distal latencies. Here, for example, the median distal latency is 7.4 with a relatively preserved velocity. The velocity 46 is not so bad, but it is a disproportionate prolongation of the distal latency. And again, we look for this entity called the terminal latency index. There's a formula for calculating that, so won't be going into that. So 0.26 is the cutoff. So whenever it is less than 0.26, it suggests that there is a predominant distal demyelination. Again, in the ulnar nerve, you can see that the distal latencies are prolonged at 5.5 with normal conduction velocities. So this is the sort of picture that we expect in a DADS phenotype. Again, the treatment is in minor cases, in mild cases, you can just monitor because it's a very indolent neuropathy, very slowly progressing over the course of years, usually. But others there are few people who do come with more aggressive phenotypes, in which case rituximab is usually preferred. IVIG can also be tried, but again, the prognosis is not as robust as we usually see in CIDP. Now, moving on to a third case. Now, this is a 70-year-old female. She has very well controlled diabetes. She is symptomatic for 10 years now at the time of presentation. She started with paresthesias in the feet with progressive ataxia, near normal power with all the deep tendon reflexes were absent. Vibration was impaired in the lower limbs, GPS was impaired at the toes, and Romberg's was also positive. So essentially a sensory ataxic neuropathy over a course of 10 years. And this is a conduction here. Again, very demyelinating conduction. The velocities are in the 20s and 30s in the upper limbs. The latencies are all prolonged. F waves are all significantly prolonged. Snaps are all absent. So her investigation showed an IgM M-band. So it's an IgM kappa M-band. Her bone marrow study was essentially normal. The PET scan, which was done to rule out POEMS, was normal. Her anti-MAG antibodies were negative, but her ganglioside profile showed a strong positivity for GQ1B antibody. So, and this is the condition that we call CANDA. CANDA is chronic ataxic neuropathy with dicyanosyl antibodies. So, briefly about this, so the more familiar term will be Kenomad. Kenomad is the more commonly known entity, but it's basically the same. They are both chronic ataxic neuropathies. So when you have ophthalmoplegia, you call it Kenomad. When you don't have ophthalmoplegia, just the ataxia, you call it CANDA. So Kenomad stands for chronic ataxic neuropathy, ophthalmoplegia, IgM M-band with cold agglutinins and the dicyanosyl antibodies. So they usually present in, again, usually 30s to 80s, slightly in the older age group are usually the patients we see here. They are very slowly progressive over the course of years, prominent sensory ataxia, usually demyelinating neuropathies on the conduction. Ophthalmoplegia is rare, so about 13% in one case series. So most of these patients tend to be of CANDA phenotype rather than the Kenomad. IgM M-band is what we really look for. And when you send the ganglioside profile, you find IgM antibodies to dicyanosyl dicyanosyl gangliosides. That is GD1B, GD3, GT1B, and GQ1B. These are the dicyanosyl Basically, they are granulocytes with two sialic acid residues, not the GM1, that is the single sialic acid residue. So this condition, Kenomad or CANDA, it may or may not be associated with the hematological malignancy. And if it's there, it's usually Waldenstrom's macroglobulinemia or lymphoma, which are the associated conditions. And the treatment, similar to the MAG neuropathy, is with IVIG or rituximab. Again, the prognosis may not be as robust as we see in CIDPs. And always, if there is an underlying malignancy, you do treat for the underlying malignancy as well. Moving on to the next case, this is a 70-year-old male. He, again, with no comorbidities, presented with paresthesias, cotton wool sensations, tremors, and gait ataxia. Normal power, absent deep tendon reflexes, impaired vibration in the toes with impaired JPS, with no stigmata of Poems syndrome. So essentially, sensory ataxic neuropathy, very indolent, very slowly progressive. He presented, I think, 7 or 8 years after he initially had his symptoms. Again, his conductions are also fairly demyelinating. The latencies are all prolonged, the 7-6 range. Velocities are all reduced. The lower limb latencies are also prolonged with reduced velocities. F waves are all prolonged. SNAPs are mostly absent with evidence of sural sparing here. And his investigations again showed an IgM band, IgM kappa M band here. His anti-MAG antibodies were negative, diacylosal antibodies were negative, and his bone marrow study is suggestive of a Waldenstrom's macroglobulinemia. So this is Waldenstrom's associated peripheral neuropathy. So Waldenstrom's it's basically a lymphoplasmacytic lymphoma, meaning when you do a bone marrow, you see not just plasma cells, but you also see atypical lymphocytes as well. And the neuropathy which we get in Waldenstrom's is usually demyelinating. And the pathophysiology, mostly they tend to be because of an immune-mediated process caused by this IgM antibodies. Again, they may be associated with MAG antibodies, diacylosal antibodies, anti-sulfatide antibodies, and other undescribed antibodies as well. But sometimes this Waldenstrom's can have IgM deposition or light chain deposition leading on to amyloid. They can have a vasculitis caused by the IgM deposition. Cryoglobulinemia can cause a vasculitic sort of neuropathy, and you can rarely have direct tumoral invasion of the nerves as well, or a neurolymphomatosis sort of presentation causing neuropathy. So when do you suspect somebody with Waldenstrom's peripheral neuropathy? So usually it is in the context of a very slowly progressive sensory ataxic neuropathy with a demyelinating conduction and an IgM M band. Sometimes these Waldenstrom's do have hyperviscosity symptoms, which is another way they present in neurology. They can have strokes, vague confusional episodes, cognitive dulling, these sort of symptoms. So it's important to look at the fundus of these patients because fundus can show characteristic features of hyperviscosity. And finally, bone marrow with the flow cytometry and the IHCs are the way to finally confirm that it is Waldenstrom's. Another entity in the paraproteinemia spectrum neuropathy is the cryoglobulinemia. So cryoglobulinemia basically means it's an abnormal precipitation of immunoglobulins at low temperatures. So these immunoglobulins in the blood, they circulate, but at low temperatures, they, especially in vitro, they precipitate at lower temperatures. Now there's a standard classification of cryoglobulinemia into type 1, type 2, and type 3. Type 1 is the type of cryoglobulinemia which is usually associated with the monoclonal immunoglobulins. So, and this type 1 usually presents with hyperviscosity symptoms rather than the typical neuropathy presentations. Type 2 and type 3, they are the mixed cryoglobulins, meaning that it's not a monoclonal protein, which is the cryoglobulin. You have polyclonal proteins. And these are usually seen in the context of chronic infections like hepatitis C, usually. Sometimes hematological disorders like Sjogren's and malignancies can also lead on to cryoglobulinemia. And what these cryoglobulin's do is they activate the complement, which lead on to formation of membrane attack complexes, leading on to a vasculitic process everywhere. So in neurology, they come with vasculitic neuropathy, but usually they do tend to have a bit of rash, bit of livedo reticularis sort of presentation, systemic symptoms, fever, weight loss. So they are all usually associated. Now, this very visual-looking slide is an excellent flowchart on how you approach paraproteinemic neuropathies. So basically, when you have a polyneuropathy, patient with a polyneuropathy, you evaluate and you find an M-band. Now, the important thing is to know what the M band really is. So for that, you need to do an immunotyping or an immunofixation electrophoresis, and you see what the M protein is. So if the M protein is just an isolated kappa or a lambda light chain, especially if it's a lambda light chain, the one neurological disorder that you're really keen on working up for is amyloid. So you look for evidence of amyloid based on biopsies of either the nerve or other tissues to confirm your diagnosis of amyloidosis. And now, if the M band is either IgG or IgA paraprotein, right? So now, that is, it is not an IgM, it is either IgG or IgA. If it's an IgG or IgA lambda, if it's IgG or IgG lambda with the demyelinating neuropathy, that is the context when you really think about POEM syndrome. So you really look for POEM syndrome, do a PET, look for any osteosclerotic lesions, look for skin changes, look for papilledema, look for volume expansion. Sometimes we do send VEGF levels as well. And if you don't find evidence of poems in such a situation, you finally treat as a CIDP. If it's an IgG, IgA with kappa, then, and if you have a demyelinating neuropathy, you're really not sure whether this is just something incidental because it could just be an MGUS with demyelinating neuropathy. Again, you treat just as CIDP. And if it's an axonal neuropathy, you are really not sure if this is at all related to the neuropathy. So IgG and IgA M bands are quite common, even especially in people older than 70 years of age. It's reasonably prevalent in the normal population also. If you see an M band in this context and an axonal neuropathy, one condition you can look for is myeloma and amyloid. But apart from that, if you don't find evidence of amyloid, obviously you work for myeloma also when you find the M band, then you need to consider alternative etiologies for your neuropathy. Now, suppose the protein that you get is then IgM paraprotein. This is when we are really interested. So IgM paraproteins with neuropathy strongly suggest that the paraprotein is going to be related to the neuropathy. Now, first thing you do is you evaluate for Waldenstrom's, you do the bone marrow, run the markers for Waldenstrom's. This can be run in the peripheral blood also. If it is positive, you take it as Waldenstrom's related neuropathy. You send for anti-MAG antibodies. If it is positive, you take it as an anti-MAG related neuropathy, treat with rituximab or IVIG. You send for your ganglioside profile, and in the ganglioside profile, if you find positive disilosol antibodies, then you label as Canomad or CANDA. And again, the treatment remains the same, rituximab or IVIG. If you find GM1 antibodies, in the context of conductions which look like MMNCB, multifocal motor neuropathy with conduction blocks, you treat it as MMNCB. And if you have a very mononeuritis multiplex sort of presentation with very painful neuropathies, then you evaluate for cryoglobulinemia. So then if it's present, again, treat for cryoglobulinemia. And if none of these is present, again, you have a demyelinating neuropathy, you treat as a typical CIDP. And also IgM can also rarely present with amyloidosis. So if none of these are fitting, it's fair to go ahead with a biopsy and look for evidence of amyloid in other areas. So moving away from paraproteinemic neuropathies, so this is a 60-year-old male. So he presented with a very acute onset of symptoms, 1 month symptoms, with an asymmetric onset of weakness, paresthesias, and pain in the upper and lower limbs. He had long flexor weakness and intrinsic muscles of the hands were weak on the right side. The right lower limb was also weak with a grade 4 proximal power, grade 2 power distally. The left upper limb showed an ulnar distribution of weakness and a very asymmetric distal predominant sensory distribution of symptoms in both upper as well as lower limbs. And these are the patient's conduction. And similar to the clinical presentation, very asymmetric sort of presentation. He has evidence for a left ulnar neuropathy. There is a bilateral peroneal neuropathy, but significantly more on the left as compared to the right. There's a right tibial neuropathy, which is not there on the left. Even the sensory potentials are also a bit asymmetric. So it's a typical, it looks like a mononeuritis multiplex sort of nerve conduction study. And his MRI brain, because the right-sided weakness was not being completely explained by the neuropathy, the MRI brain showed a left internal capsule infarct, so which is partially the reason for the rest of his right-sided weakness. And his evaluation showed a total count of 18,700 with 45% eosinophils. So that would be an absolute eosinophil count of 8,450, which means he has hyper-eosinophilia. AEC more than 1,500 is what you take as hyper-eosinophilia. In that context, you also have high CRP, high ESR, and there is some evidence of a glomerulonephritis sort of picture with urine showing 15 to 25 RBCs, and his MPO and p-ANCAs were positive. So again, while we were waiting for the MPO p-ANCA reports, he underwent evaluation for the hypereosinophilia as well. A bone marrow was done, which showed increase in the eosinophils and its precursors. But apart from that, a normal bone marrow. Workup for eosinophilic leukemias and myeloproliferative neoplasms were negative, both in the bone marrow as well as peripheral blood. Now, biopsy was suggested, but the patient was not willing for the same. But because his MPO and ANCAs came as positive, in the context of this asymmetric neuropathy, mononeuritis multiplex sort of presentation, he was diagnosed as EGPA. EGPA is eosinophilic granulomatosis with polyangiitis, what used to be called the Church-Strauss syndrome. And this patient is doing well on cyclophosphamide. Initially was on steroids, brought out, and now on cyclophosphamide. So quite similar to this case is the second case. This again is a 55-year-old male. He came with about 12 months of symptoms. His symptoms were not really neurological symptoms to start with. He had a chronic cough, bit of wheezing, abdominal pain, prominent abdominal pain, and dyspeptic symptoms for which he initially actually went to the gastroenterologist. During the evaluation, he was found to have eosinophilia. And during the course of his illness, he gradually started developing these lower limb symmetric paresthesias with cotton wool sensations, bit of distal weakness. So examination, when he came to us, he had pedal edema, symmetric reduced sensation in the feet, toe flexor weakness. He could not walk on his toes. So he was initially diagnosed with hypereosinophilia, treated with steroids, but he was relapsing on tapering steroids, which was the reason why he came to our center. So his evaluation at that time, he showed a total count of 35,300 with an absolute eosinophil count of 26,000 odd. His ESR and CRP was also raised. MPO, PR3, ANCAs were negative this time. And he had biopsies from multiple sites in his GIT, which showed eosinophilic infiltrates with no vasculitis. There's no evidence of vasculitis in any of his biopsies. Again, bone marrow was done for evaluation of the hypereosinophilia syndrome, including a fish panel for myeloproliferative neoplasms, and it was all negative. There was no evidence for eosinophilic leukemia or such other disorders which can cause hypereosinophilia. And finally, he was diagnosed with idiopathic hypereosinophilia with neuropathy. And this patient was started on steroids and imatinib, and now currently he's on remission. So both these cases, they are both cases of peripheral neuropathy with hypereosinophilia. So whenever you have neuropathy in the setting of hypereosinophilia, two entities that we really think of is one is the idiopathic hypereosinophilia syndromes and the EGPA, that is Church-Strauss syndrome. Now, they are very similar disorders, very difficult to differentiate between the two quite often. There are no really validated biomarkers for differentiating them also. So when you have a neuropathy, which is a mononeuritis multiplex sort of presentation, you tend to favor more of an EGPA. If you have ANCA positivity, again, strongly suggest you have EGPA. And if you have evidence of vasculitis on any of the biopsies, again, that would favor an EGPA. But again, sometimes idiopathic hypereosinophilia can also lead on to eosinophilic infiltration of the vessel walls, causing some vasculitis-like appearance. So the point is that often EGPA and hypereosinophilia syndromes can look quite alike, and there are entities called overlap syndromes, EGPA, hypereosinophilia overlap syndromes also. So moving on to a different spectrum of cases, this is a 45-year-old male. He is a known case of DLBCL, that is diffuse large B-cell lymphoma. He's already undergone 6 cycles of chemotherapy, and his last PET scan was showing resolving lesions, and his PET did not show any evidence for any neural involvement. And he presented 2 days after an intrathecal methotrexate injection with neck pain, paresthesias in the right medial arm and forearm, with weakness of his interossei, the abductor digiti minimi, APB, extrinsic pollicis, overall looking like a CAT1 sort of distribution of weakness and sensory symptoms. He also had a positive Tinel sign in the supraclavicular fossa. Because it was happened, these symptoms happened immediately following methotrexate intrathecal injection. One possibility considered was arachnoiditis as part of methotrexate. Again, he was evaluated for this. MRI and C-span was already done when he had come here, which of the brachial plexus was essentially done. So it was reported as normal, though we were a bit concerned that there was a bit of hyperintensity in the plexus. As NCS and EMG showed evidence of a right lower brachial plexus involvement. The CFS study was done, which was completely normal. So, because there was a concern for a neurolymphomatosis, he was taken up for a PET MRI, and the PET this time showed a lesion along the course of the right brachial plexus. So, he was diagnosed with neurolymphomatosis. So neurolymphomatosis basically means it's lymphoma, which is lymphoma or neoplasms in general, which are spreading along the course of a nerve. So usually they tend to occur in the context of a known lymphoma when it's called secondary neurolymphomatosis. But sometimes this can be the primary presenting symptom. In up to 40% of the cases, patients of neurolymphomatosis, they are the presenting symptoms which brings the patient to the hospital. And when you evaluate for a nerve involvement, thinking neurolymphomatosis, sometimes you can have an isolated neurological involvement also without evidence of lymphoma anywhere. So it's quite important in such situations to biopsy the nerve to really look for what the pathology is. And the general setting of neurolymphomatosis is in the setting of DLBCL, that is the diffuse large B cell lymphoma. That is the most common type of, it's one of the most common types of lymphoma, NHLs or non-Hodgkin's lymphomas also, and sort of bad non-Hodgkin's lymphomas. So they are the sort of neoplasms which usually presents with neurolymphomatosis. Again, the presentation, this neurolymphomatosis, when the patient presents, usually they have patchy involvement at multiple areas, not just one area. So nerve roots and peripheral nerves are the usual sites, but it can also involve the plexus as well as the cranial nerves. And the treatment, so you can go for systemic or intrathecal chemotherapy. If it's a very focal lesion, radiation is used. Also for palliative purposes, for pain, radiation may be useful. Again, stem cell transplant and CAR-T are the other treatment options for neurolymphomatosis. Finally, I'll just briefly talk about chemotherapy-induced neuropathies as well. So the usual drugs, the usual suspects in this situation are bortezomib, especially in the setting of myeloma, and vincristine and the platinum-based compounds, that is cisplatin, carboplatin, oxaliplatin, and paclitaxel. So because we are dealing more with hematological disorders, I'll just talk about bortezomib-induced peripheral neuropathy. Usually, these patients present with very painful sensory neuropathic symptoms involving the lower limbs. This is the usual symptom. Rarely, you can have motor deficits as well quite later on in the course. And there is something called coasting effect. Coasting effect is more commonly described in the platinum-based compounds rather than in bortezomib. Coasting effect basically means that if even after stopping bortezomib, sometimes the neuropathy can continue to progress. Sometimes the neuropathy can begin after stopping the drug also. This is called the coasting effect. So the incidence, so again, the lower grades of neuropathy can happen quite frequently. The study shows the nearly 34%, but again, it may be quite higher also. And the risk factors for the development of bortezomib-induced peripheral neuropathy, one is the chemotherapy regime that is used. So the typical regime is the 1-8-15, that is weekly cycles of bortezomib, which is repeated every 3 weekly or 4 weekly, usually 3 weekly. So that is a fairly safe regime, but there are, when the disease is aggressive, sometimes they use twice weekly regimes, which makes the risk of neuropathy quite higher. Also, the route of administration. Sub-Q is the preferred route of administration for bortezomib, but IV is used, and if IV is used, your chances of neuropathy are significantly higher. So, higher age and female gender are risk factors for development of neuropathy in bortezomib. And there are certain genetic variants, some single nucleotide polymorphisms, which place you at a higher risk for developing bortezomib-induced peripheral neuropathy. So when you have any chemotherapy-induced neuropathy, it's important that you grade the severity of the neuropathy. So the most commonly used grading system for chemotherapy neuropathy is the CTCAE grading. That is the the chemotherapy clinical adverse effects grading. It is there for all sort of chemotherapy related side effects. So in the context of neuropathy, this is the CTCA grading of neuropathy. So when you have a grade 3 or 4 neuropathy, grade 3 or 4 means it is impairing your activities of daily living. Grade 4 meaning it can be life threatening also. So when you have a grade 3 or 4, that is when you really think about stopping the chemotherapy. Again, this decision needs to be taken in consultation with the treating hematologist or the oncologist, because the chemotherapy itself is likely to be life-saving. So just because of neuropathy, we may not always suggest to stop the chemotherapy. Sometimes they can think about reducing the dose of the chemotherapy or switching the drugs to more safer options. And the prognosis and management. Most patients of bortezomib-induced neuropathy, the symptoms tend to resolve or at least improve in 3 to 6 months after stopping of bortezomib. So that is something which is we always tell the patient. So once you stop the drugs and once the disease is under control, the chances are that your neuropathy will improve. That itself is very reassuring to the patient. And for symptomatic relief, the data, trial data basically has evidence mostly only for duloxetine, but we often use other drugs also, our usual gabapentin, pregabalin, other gabapentinoids. These are all used to varying degrees of success. And there are anecdotal reports of success of immunotherapy in bortezomib-induced peripheral neuropathy. Steroids, IVIG have been tried, but they are not the standard of care. There are just a few reports on these conditions. And usually those conditions where it was successful, the neuropathy pattern was also quite suspicious. They had a bit of demyelinating neuropathy, almost like a GBS-like presentation. So again, I don't think it's fair to generalize as immunotherapy would be useful in bortezomib-induced neuropathy. So I think that's the last slide. Thank you.
Thank you so much, Gopi, for that overview. But you have covered most of the aspects. I think you have covered peripheral neuropathy very well. Let's see whether anyone has any questions. So, if so, you can put it in the chat box, or if you can raise your hand, we'll unmute you because we have some 10-15 minutes more. Anyone? So, um, can I ask you a couple of questions, Gopi?
Sure.
It's related to, yeah, this bortezomib we have started using in very difficult cases of NMD encephalitis, which comes with the repeated relapses and all. So we
Right.
use, you were talking about the peripheral neuropathy, which I thought it was a very minor problem only. But is it dose related, or how frequently you administer the drug, or are there any predisposing factors for it, like
Yes, ma'am.
gender?
So yes, ma'am. So basically, there is a cumulative dose which increases the risk of developing neuropathy. So when we use bortezomib in autoimmune encephalitis and NMDA, we don't tend to prolong it too much. We give a few cycles, but and then we usually stop it. Such short cycles, few cycles, usually does not cause much of neuropathy. The problem happens, one is in the context of plasma cell dyscrasia when you already have a tendency for developing neuropathy. Also, elderly patients who have diabetes, other comorbidities, or pre-existing neuropathy, they are the situations when they really worsen, especially if you're giving only 1 or 2 cycles. In the context of myeloma and generally hematological diseases, because they have to give for a prolonged period of time, that is usually when they develop clinically significant bortezomib-induced neuropathy. I don't think with our use we also do give quite frequently nowadays, but we rarely see neuropathy as an issue. Cytopenias we've had, but neuropathies I don't remember having much problems with neuropathy so far.
Yeah, that's what I thought. And about imatinib, can you just enlighten us on what all conditions do you use that, and is it frequently available outside?
So actually, we don't use imatinib. The hematology people they frequently use. It's usually used for myeloproliferative neoplasms. So it's indicated in CML is the usual situation where they use imatinib, but in other myeloproliferative neoplasms also, especially in hypereosinophilia, primary hypereosinophilia also, and in hypereosinophilia with certain specific mutations, imatinib is the drug of choice. So imatinib is not something we start from our side. So whenever we have these issues, our hematology colleagues are involved, and they are the people who usually start imatinib.
Okay. So my one last question is: we have a patient in the ward with a hypereosinophilic syndrome,
Yes,
um,
ma'am.
either EGP or IHES. It could be anything. We don't have a diagnosis right now.
Yes, ma'am.
So peripheral neuropathy is not there, but multiple cranial nerve involvements are there. So have you? What is your take on it?
So generally asymmetric sort of presentation in hypereosinophilia syndromes, primary hypereosinophilia syndromes, what is more commonly described is the as very symmetric sort of polyneuropathy. When individual nerves are being involved, generally you tend to think more in terms of vasculitis or EGPA sort of entities. But then again, this is they are sort of considered to be along a spectrum, EGPA, idiopathic hypereosinophilia. Quite often you may not be able to really differentiate between the two. It's also important to rule out myeloproliferative neoplasms, eosinophilic leukemias. So workup for bone marrow and the FISH and flow cytometry panels to rule out these are also important. But my understanding is generally when you have this multiple cranial nerve, multiple mononeuropathy sort of presentation, you tend to think more in terms of EGPA rather than primary hypereosinophilia.
Cranial neuropathies are described, and when there is an associated hypereosinophilia also, is there a vasculatic component to it, or how does it affect the cranial nerves? Was my question, and like the peripheral
So
nerves.
primary histophilia. No? Primary histophilia, it's
Yeah.
basically if you do a biopsy of the nerves, you will find eosinophilic infiltrates in the endoneurium. That is the usual pathology. You may not see a vasculitis. It may not be a perivascular infiltration of this of the eosinophils causing a vascular occlusion causing symptoms, but a diffuse infiltration of the nerve which causes the inflammation. Usually in hypereosinophilia syndromes, but they can have vasculitis also. So it's a very gray area differentiating between EGPA and unless you have strong ANCA positivities or MPO
Okay.
PR3 positivities.
And cyclophosphamide would be better. That's what you think, no? That's what I
Um,
understood.
so usually nowadays for ANCA-associated vasculitis, rituximab is preferred over cyclophosphamide by the rheumatologists in general. But our patient, he had taken cyclophosphamide because of financial reasons, and he was progressing pretty fast, and rituximab takes a bit of time to act. So we had given the first dose of cyclophosphamide. He went into remission immediately after that. But usually, ANCA-associated vasculitis, now the choice is leaning more towards rituximab than cyclophosphamide.
Okay. So we have a couple of questions here. When do you suspect paraproteinemic neuropathy, and how frequently you encounter this entity?
Um, so, so any patients, say after the age of 50 who has a neuropathy, we always look for evidence of paraproteinemia. We always send at least a serum protein electrophoresis. You should be much more aware. I mean, if it's a very small fiber neuropathy sort of symptoms with prominent autonomic symptoms, amyloid is something which we always look for. And again, if it's a demyelinating neuropathies in the elderly, especially when they're refractory to usual treatment as lines of CIDP, that is another situation we really look for paraproteinemic neuropathy because they don't really respond so well like CIDP. But in general, if we don't have an etiology for a neuropathy, we always do look for paraproteinemic neuropathies. We rarely find them. It is not a common entity, but we do get once in a while. And because we get a lot of referrals from hematology, who are known cases of paraproteinemia and they develop neuropathy. So that way we do see a few patients. But primarily when you talk about patients presenting with neuropathy, even though we look for them almost always, but the yield is quite less. We do find them, but they're not. Maybe in a year we see maybe 4 or 5, I guess. Maybe yeah, of primary neuropathies who end up being paraproteinemias.
Okay. Sapna, Kiran, any
Um,
questions? Okay. So one last question, can you repeat what is costing effect for my resident sitting here?
Coasting. So coasting means it generally is described in the setting of platinum compounds related neuropathy. So generally our understanding is if you stop the offending agent, the neuropathy would eventually settle and improve. But in a few cases, even after stopping neuropathy, or even after stopping the chemotherapy, the patient's neuropathy will worsen, or sometimes the neuropathy may itself begin after the course of chemotherapy is over. This is called the coasting effect. So the reason why this happens is not very clearly understood. I think a bit of cellular level mitochondrial pathologies, and there are a lot of postulates at this level, but the reason is not very clear. But this is something which is well described, especially in platinum compounds, but also in bortezomib-induced neuropathy, also coasting is described.
Okay, Gobi. So I think these were the questions, and it was a very wonderful session. And I thank you profusely from the Department of Neurology and all the other people in the audience. Thank you. Thank you so much.
Thank you, man. Thank you for the opportunity also.